All right. Hi, good afternoon, everybody. My name is Sona. I'm a speech language pathologist. Maybe I'm the lone non-physician speaker today. So, oops, I'm going forward with this. And as you know, a speech language pathologist, most of you may know that we work mostly with communication disorders, but we do definitely work with swallowing problems also. So as per Dr. Tariq's request, I'm going to talk to you mostly about the swallowing disorders and how a speech language pathologist works with patients who have swallowing problems. So as you see, we diagnose and treat cognitive communication and language disorders and or swallowing problems. But we function as members of a multidisciplinary team or interprofessional treatment teams. And we provide counseling to patients and their families. We educate other healthcare staff about cognitive communication, language, and swallowing feeding disorders. And as Dr. Rana mentioned, we work in many different types of teams. So I myself is a part of multiple team clinics that we have. So one such team is the pediatric nutrition support, where we have the general pediatrician, the gastroenterologist, the dietitian, me as a speech language pathologist and a psychologist. So this team can vary, but in and around we are there to serve the needs that the child requires. And mostly what I do is feeding disorders. Now, you may wonder, or some of you may wonder, what is our role as a speech language pathologist in dealing with dysphagia or feeding disorders in children? So we play a central role in the assessment, diagnosis, and treatment of infants and children with swallowing and feeding disorders. And the professional roles and activities in speech language pathology include clinical education services and prevention and advocacy, education, administration, and research. And this is common even for communication disorders. And for us, we follow the ethical guidelines by American Speech Language Association, or Speech and Hearing Association. It's called ASHA, and they establish the primary roles and responsibilities of the SLPs, in short, in the neonatal intensive care unit, the NICU, breaking down the skills and knowledge needed to become a member of the neonatal team. And it's still developing because, as many of you know, some of you know that we work with feeding disorders, some of you don't know that we work with feeding disorders, but they may be among the first specialists to see a medically stable neonate, an SLP. And a neonate's ability to gain weight in the days and weeks after being born comes down to the ability to feed. And an SLP can be the key to making that happen. And weight gain in neonatal or newborns have been shown as a predicting factor in the baby's ability to avoid future complications can result in premature birth. Now, swallowing disorders, which was briefly discussed by Dr. Rana, and it can occur in one or more phases of the swallowing. That's the oral, pharyngeal, oropharyngeal, or the esophageal phases. That's the passage of food, liquid, or saliva into the trachea and retrograde flow of food into the nasal cavity. And the long-term consequences of feeding and swallowing disorders can include food aversion, oral aversion, aspiration pneumonia or compromised pulmonary status, undernutrition or malnutrition, dehydration, gastrointestinal complications, poor weight gain or again malnutrition, rumination disorders, ongoing need for enteral feeding, psychological effects on the child and the family or caregivers, feeding and swallowing problems that persist into adulthood, including the risk of choking, malnutrition, or undernutrition. Now, what's a pediatric feeding disorder? It's a range of it's a disorder with range of eating activities that may or may not include problems with swallowing. Now, it is defined as an impaired oral intake that is not age appropriate and is associated with medical, nutritional, feeding skills, and or psychological dysfunction. And it may be associated with oral sensory function and can be characterized by one of the following behaviors. There can be refusal of or age-appropriate or developmentally appropriate food, accepting a restricted variety or quantity of food or liquids, displaying disruptive or inappropriate mealtime behaviors, failing to master self-feeding skills expected for developmental levels, failing to use developmentally appropriate feeding devices and utensils, experiencing less than optimal growth. Now, these are some of the problems related to the various phases of swallowing, because if I go deep into that, I think I'll run out of time. And now feeding management, what do we do? It starts right from birth with primitive reflexes such as sucking and rooting. And the issues that we commonly face are weak suck, choking, poor feeding, fussiness during feeding. And because infants are often passive participants in the feeding process, the NICU SLP can expect to work as much as with new parents as with babies themselves, because we need to guide them. Because the parents could be worried as to why the baby is not orally feeding, because when a baby is born, the mother expects, okay, the baby is going to start breastfeeding. And thus our job would mostly include parent caregiver education and counseling, parent empowerment, culturally sensitive delivery of educational contents. And some of the common diagnoses that we come across, these are just some of them, are failure to thrive, ex-preterm, Down syndrome, laryngomalacia, tracheomalacia, or other airway disorders, GERD, developmental delay, orofacial anomalies such as cleft lip and palate, cardiac disorders, and etc. Overview, our role can be a bit challenging because babies cannot express themselves and they're very fragile. And it's not until they reach 40, almost 34 to 40 weeks of gestation that all muscles required for normal feeding are fully developed. And with children with certain childhood diseases, it can take even longer. All premature babies are at a risk of experiencing feeding difficulties, and many preterm and very low birth weight infants are born with physiology and reflexes that are too immature for successful breastfeeding or bottle feeding, and feeding ability decreased with both gestational age and birth weight. Many preterm newborns lack the organization necessary to successfully coordinate sucking, swallowing, and breathing, which can put them at risk of aspiration, which was discussed before, and make oral feeding extremely dangerous. And thus the knowledge that I would require as a speech language pathologist dealing with neonates or pediatric feeding would be normal embryology, perinatal and postnatal infant development, atypical infant development, family-centered practices, and team-based processes or approaches. Now, what would I do when I go to see a patient in the ward? What would my bedside assessment be? So I would first look for the baby's level of alertness. Is the baby on oxygen or any kind of enteral feeding? Oral reflexes, if it's a kind of a newborn baby, is there any rooting and sucking reflexes, which is quite normal in normal babies? Infants' behavior, beginning with muscle tone, alertness, and non-nutritive suck. If I put my finger in the mouth, is the baby sucking? Or if I put a pacifier, is the baby sucking on it? Look out for signs of distress, such as increased heart rate or respiratory rate or desaturations. Other signs can be irritability, crying, or turning blue during oral feeding trials, or even by just touching the baby. And non-nutritive stimulation, oral feeding, and then I would just go in for oral feeding trials and look out for any issues at bedside. And the instrumental assessments that I would do is a modified barium swallow study or a video fluoroscopic evaluation of swallow, and or if required, fiber optic endoscopic evaluation of swallow, which is not commonly done for pediatrics in UAE. This is just a sample video of what I look for in the video fluoroscopy. You would see aspiration. It doesn't work. It didn't work the last time also. Yeah, there. If I just repeat that, you would see aspiration happening there. You see the little black line over there? That's like deep aspiration. The milk has, or the contrast that I've fed the patient has entered the airway, and that's definitely risky. That's one of the things that I would look for. Now, intervention. Once the SLPs have diagnosed any feeding issues, they will work in conjunction with the rest of the team to develop a treatment plan. And mostly if we feel that the patient has unsafe feeding, and then we try different consistencies of liquid, different consistencies of food, then we would go for enteral feeding if we say none of that is safe for oral feeding. And if we say that the patient is deemed safe for oral feeding, then we make a plan to slowly wean off the enteral feeding if the patient is on any kind of enteral feeding. And this may include improving their food intake, shorten the length of feeding sessions, or increasing the baby's comfort as assessed by various visual or behavioral signals offered during the feeding. And then we would look at the non-nutritive sucking for the purpose of coordinating the suck, swallow, breathe, for the safe oral feeding, oral perioral stimulation, sensory desensitization. And oral feeding should be guided by infants themselves and create their own infant-centered semi-demand method for helping infants transition from enteral feeding to oral feeding. It's better to feed them on demand rather than forcing them to feed at a time that we wish them to feed. And infants fed using semi-demand method reach full oral feeding and readiness for hospital discharge an average of 5 days sooner than those fed on a fixed schedule. And breastfeeding can also be encouraged, which is much better than formula feeding. And once the babies are ready to go home, and as they grow, these children may have medical conditions or developmental challenges that require special attention. And this may include services such as nutritional, medical, neuromotor, developmental, psychological, and psychosocial evaluation and treatment. Early coordinated interventions to address concerns related to child health and development can make sure they continue to grow and develop new skills. Now, feeding therapy, just to go quickly into what we do. So if the patient is deemed not safe for oral feeding, we keep the patient nil by mouth and continue only enteral feeding. So then what is my role in such a case? So we make opportunities for production of purposeful swallows for oral skill development so that we don't leave the patient not to be fed at all, that they forget how to use their mouth for oral feeding. So we stimulate them with tastes, which can be part of the daily routine for children with cerebral palsy, with rare exceptions. And children receiving nutrition and hydration via the tube should be appropriate for brief taste sessions over 2 to 5 minutes, multiple times per day. And spoon presentations with very small amount of water or flavored water may be tolerated without compromising pulmonary status. Older children who are not safe for to take nutrition orally can be given opportunities to mouth toys or to put their fingers into food and suck on their fingers with a minuscule amount of food on them and to accept 2 or 3 drops of water via teaspoon. Now, oral feeding initiation. Once it requires coordination of nutritive sucking, swallowing, and breathing. So it's not initiated in preterm infants up to 32 weeks of postmenstrual age, and mainly because the coordination of sucking, swallowing, and respiration is not established until then. The suck-swallow respiration coordination is a critical factor in achieving safe and successful oral feeding in preterm infants. Sensory intervention is used to improve oral feeding, that is, the provision of developmentally appropriate oral, tactile, kinesthetic, vestibular, and auditory inputs to facilitate the development of existing skills. We identify the food texture or liquid consistency that is safe for the baby, gradually reduce enteral feeding to stimulate hunger, and trial oral feeding. And now we modify the diet as per the video fluoroscopy results that we have to prevent choking or aspiration pneumonia. And it can be determined on the basis of the results of the swallow study. Silent, sometimes life-threatening aspiration can occur as a result of weak cough and post-swallow residue. Regular reassessment is necessary to evaluate disease progression or regression and the effects of intervention. In the case of mastication problems, softer foods and smaller pieces of food are recommended. Now, oral aversion therapy or desensitization, I see a lot of patients who come to me, they've been on enteral feeding for a long, long time, thus they don't know what to do with their mouth when food or liquids are presented. So we work with non-nutritive sucking, that is providing a pacifier for the patient so that they re-establish their sucking skills. Swabbing, just simply swabbing the baby's lips or mouth so that the areas remain stimulated. Cue-based feeding, feeding the babies it's more about the quality than the quantity. So instead of stressing over the amount they eat, we focus on how to make the eating a positive experience. And pacing, is the baby pausing to catch their breath? Then we just need to pace the oral feeding or the bottle feeding so that there's no incoordination in their breathing and swallowing. And if you're dealing with a picky eater, then we have to look into the food preparation and make eating more fun. And also, we have to see to it that the parents are able to understand what they need to do with the babies and don't pressurize the babies to eat, make it a pleasurable situation for the babies to eat, play with tea sets so that they understand the concept of eating, arts and craft with food, let them play with the food. They may not eat it, let them play it, they let them throw it around, but one day they're soon going to put it into their mouth. And it should be a step-by-step procedure. And lastly, we have to be patient with the babies. And this is just a graph or a flowchart of behavioral feeding interventions, which has environmental methods, reinforcement methods, and inhibitory methods. Now, vital stim is something that I'd like to talk about. It's a neuromuscular electrical stimulation and dysphagia management, which is steadily growing in Asia. And I'm practicing that in Sheikh Khalifa Medical City. It's a non-invasive therapy that uses electrical current to stimulate the muscles responsible for swallowing. And it's a modality for dysphagia management, which is being adopted by an increasing number of professionals in the Asia Pacific. And case studies show improvement in swallow after the neuromuscular electrical stimulation treatment, along with traditional swallowing exercises or therapy. And however, much research or study has not emerged from the Middle East area. Now, I have done this for both adults and pediatrics, and I have seen success. And it uses a device that sends electrical impulses to the nerves. This input causes the muscles to contract, and the stimulation can increase the strength and range of motion and offsets the effect of disuse of the muscles. In a clinical trial of nearly 900 patients using VitalStim, more than 98% showed improved scores in swallow function. And more than 97% of the patients with severe dysphagia regained their swallow function, fast feeding tube reliance, and nearly 40% regained full swallowing ability. Now, each session begins by putting the electrodes, that they're like small stickers with wires connected to the device on the front of the child's neck, or it can even be the child's lip, whichever muscle that we have identified to be weak and that we need to work on. And they may feel a slight stinging or pin or needle sensation. As the input is increased, the sensation will feel like more of a tugging and a pulling. Most children are able to tolerate the therapy with little difficulty, and every attempt will be made to make the child as comfortable as possible. And it's important that the child is hungry during the session, because they will be encouraged to eat or swallow as much as possible during this electrical stimulation. Clinical observation as well as follow-up video fluoroscopy swallows studies are used to track the child's progress, and most treatment sessions are within 40 to 60 minutes. And therapy sessions are repeated between 3 to 5 times a week until the swallowing patterns have been restored to a nearly normal level. And patients frequently see dramatic improvements in 6 to 20 daily sessions, sometimes as little as 3 days. Now, I have a few case studies about the patients that I have dealt with, that I've treated them with VitalStim. We have baby J, who's currently 10 months old, and a history, significant degree of hypoxic ischemic encephalopathy secondary to placental detachment, and he was left with spastic quadriplegic cerebral palsy, necessitated the use of baclofen, the reason behind which his current muscle tone is only flaccid side. And he has also got significant degree of head lag. Now, video fluoroscopy that I did in June showed that this child was silently aspirating on thin consistency, but tolerated nectar thick consistency and pureed food. And thus I advised to start puree per oral trials with puree food. So he attended 20 sessions of VitalStim therapy done along with feeding trials with me. That was 2 sessions per week. And a video fluoroscopy in September showed aspiration not seen in any of the consistencies, that's including the thin consistency. And as of the 31st of October that I saw him, he was drinking thin milk without overt signs of aspiration, and also eating purees 3 to 4 times a day, and the NGT has been removed. Baby S, who's currently 11 months old, history trisomy 21, AVST, post-cardiac surgery, video fluoroscopy in June, showed frank aspiration with thin consistency, tolerated nectar consistency, attended 15 sessions with me along with feeding trials, and a video fluoroscopy done 2 weeks ago showed no aspiration with thin consistency. Again, I saw this patient in my clinic on the 31st of October, drinking thin milk with no signs of aspiration, also eats purees 3 times per day, and the NGT has been removed. This is a little more of a complicated case. Patient A, currently who's 5 years old, history, ex-preterm, IVF baby, twin 1, congenital AVST, global developmental delay, severe retinopathy, chromosome 3p deletion, currently on PEG tube feeding. They were not orally feeding her up until 6 months ago. Started VitalStim therapy with me since April 2022, attended 12 sessions, and then we did video fluoroscopy in June 2022. Aspiration was seen with thin, laryngeal penetration seen once with nectar thick consistency, tolerated honey thick liquid consistency, and I said we can start oral trials with honey thick consistency. We started feeding therapy along with VitalStim since then, and has attended 17 sessions. This has not been an easy case because this child has behavioral issues also. So currently we're just trying oral feeding trials with her 1 to 2 times per day, but definitely there has been an improvement from nothing to some kind of stimulation. So the main goals include increasing the amount of food or liquid that the child will eat or drink, the variety of the food the child will eat, promoting development of feeding, such as cup drinking, self-feeding, and oral motor skills, transitioning from tube to oral feeding, teaching caregivers to manage feeding problems at home. It's a teamwork. We need to have a strong rapport, provide education to other team members through informal or formal in services, ideal time to share knowledge on specific topics and inform others, and regarding the role of SLP, example on dysphagia and dietary recommendations to dietitians, feeding strategies to be explained to the ward nurses or other clinical caregivers on how to feed the baby in the ward, on communication approaches for the NICU and PICU nurses. Came again. Conclusion. Our clinical practice in a pediatric hospital can be challenging, but preparation and education are the best ways to meet the challenge, and establishing a good rapport with other team members and caregivers is very important. My references, thank you.